we'll get started. Good afternoon. The last of the parent sessions for this conference. We're talking about urinary health. And we have Laura, Sheri, Alyssa, and Sarah. You guys are in order. Great. Before we get started, as we've been pitching various things about the foundation and what we do and how we do it during these sessions, one of the things we do want to talk about with everybody and ask everybody is talk about engagement in the research and data gathering that we're doing. And I know that a lot of you have done, is this on?
I think there's a switch at the base.
Technical difficulty.
Oh yeah, there we go. How's that? Is that better? We'll talk a little bit about engagement in research and data gathering. And thank you all for joining in with our researchers while they were here today and yesterday. But it's incredibly important and really vital that we get the information back from all of our families as much as possible. Because we are all the experts in our syndromes, that we know that the doctors and the clinicians and the scientists are not actually experts. They are the experts in what they do, but we are the experts in everything holistically about our kids and how they've progressed through time and how they've progressed through their life. So we know that there are going to be, especially moving forward as we really pick up on the research, that there are going to be more and more surveys and questionnaires that are going to be coming out from doctors, from the foundations, and it's really, really important. And we know that they're long and exhausting, and the ones we try to put out are, we try to keep that in mind because we know we're all busy, but it's incredibly important. I can't stress enough just how important these surveys and questionnaires are to us and to the doctors and scientists who are working on finding therapies and understanding the disease mechanisms. So please take every opportunity you have, and I think Bianca is going to talk a little bit about that later today, the closing session, but please take every opportunity you can to contribute to the body of knowledge on ASXL syndromes, official research studies, or data collection efforts that the Foundation is doing going forward. So thank you for that. And with that, I think we've done all the housekeeping over and over again, so I will let everybody take over from here. Thank you.
Okay, great. Thank you so much. My name is Laura Badmaev. I think most of you know me by now. I'm the chair of our foundation. My son, Alex, here is 11 years old. He has Bohring-Opitz syndrome. Alex has pretty limited mobility, and so he's mostly in a wheelchair. He communicates with a Tobii Dynavox eye gaze device, and he has some nonverbal gestures. So we're from Maine. We're thrilled to be here with all of you to talk about urinary health. So Alex, we started toileting him when he was around 6 years old. Initially, we put him on a potty chair, and eventually we got here this routine hygiene seat to give him more back and lateral support. We would put him on every couple hours to create some type of routine. For communication with this, we initially used a bar of soap on a placard because he has visual impairments as a choice option, but as he got older, we started using more of the eye gaze device. Sometimes he would also just like this, and you knew he had to go to the bathroom, right? He also communicates while he's on the toilet, so he'll squeeze my finger if he has more, I'm still working on something, or he'll put his hand flat or pull it away when he's all done, which is very helpful. But last year, he was spending a lot of time on the toilet at school, and sometimes he was crying when he was peeing. And this started to become worse after he had a whole bunch of orthopedic surgeries on his feet and he wasn't weight bearing. And so while we were in the hospital for a week, they started to scan his bladder multiple times a day, and they noticed he had more retention. And they said, why don't you come and follow up, and we're going to do some more sophisticated scans. And when we did that, we found out that Alex's urinary system was actually not working properly. So this is one of the scans you can see that we did. So what we found out was, so Alex has what's called a neurogenic bladder, and what happens is the signals between his brain and his bladder are not functioning properly. And these neurogenic bladders can appear in many different ways. Sometimes they have increased urinary retention, sometimes they're frequently urinating all the time, they might be dribbling pee, it might be painful to pee. And I personally believe that there's actually many undiagnosed cases in our ASXL community. And these can be treated with medication, behavioral therapy, surgery, or a combination of these. So the way to find out whether or not you have a neurogenic bladder is to do what's called a urodynamic study. And there's different versions of this. So we initially had one done locally. It didn't have as much data. So we went to Boston Children's. And the urodynamic study that they do also has this needle electromyography, the EMG. And so with that, they can see the bladder spasms, which can be quite painful for our children. And that's something I wonder about when they have pain, if this is one of the potential causes. They also do this test here called VCUG. And what that will show is, so it looks at the size, shape, and capacity of the bladder. So if you think about like a normal bladder, it's round, it's soft. You know, the urologist described Alex's bladder like a melting snowman with a shell of a walnut. So it's very tight, right? And what happens is the urine, like that's not coming out, is going up, and it's refluxing into his kidneys. So he has what's called grade 4 reflux. There's renal scarring. Now he's at risk for renal failure. So that becomes a big problem if you have an infection in your bladder and then it's going up into the kidneys. It can be very serious and potentially fatal. So another way to check, so not all doctors may be willing to do this VCUG test because there's not evidence, right? Like no one has published that ASXL syndromes have this, right? So one simple test is looking at a blood test for what's called cystatin C. So Alex had completely normal metabolic panels. Everything was fine. You know, most doctors, they look at what's called GFR. It's like the filtration rate of your kidneys. That looked all normal. So the cystatin C is a more purified test where they can actually see what's really happening, which is more applicable to our children. So part of the challenge, especially with kidneys, is there's organ redundancy, right? Like our bodies are developed to do as much as possible and to protect. And so, we're trying to do everything we can right now to slow down his chronic kidney disease. One of the ways you can do that is through medications, these bladder relaxants, so that instead of the urine going up into the kidneys, it's calming. But initially we tried this oxybutynin and he stopped eating altogether. So, I would say another thing that we had to do with that is the fraction dose, which, we've anecdotally seen even in other medications, like our children just may not need the full dose that a neurotypical child needs of certain meds. Like sometimes it just start lower and go gradual. And there's also another one called Miravetrix, which is a crystal that they convert. He's permanently now on antibiotics because that will help his kidneys if there is an infection. And then the other thing is to avoid any kind of NSAIDs like ibuprofen or Motrin, because that can also be pretty damaging to your kidneys. So to counteract the antibiotics, which obviously is not ideal, is to take probiotics, which can also help for a lot of the GI. So Culturelle is one that we use that has a lot of really great probiotics. And then the other thing you have to consider is with the GI, things like constipation also cause retention, right? But there's all these different specialties. So, increasing your water intake, weight bearing and mobility, looking at your diet, things like prunes, applesauce, oats. There's one thing I would highly recommend, since many of our children do have a lot of GI and other challenges, is Dr. Wheel's anti-inflammatory diet. There's a pyramid and it's on the handouts in there. Another thing, we always try to look at other options besides drugs. Pelvic physical therapy has been amazing, and this is something you can use for GI. It can help with toileting. It can help with catheterization. There's a lot of different ways this can be helpful. It's a specialization within physical therapy. And so, once Alex started having urinary issues, I want to show you a video here. Oh, I have to go back. We transitioned his plan from, doing, initially it was more oriented around toileting. Now we're more oriented around catheterization. So, it can help for both, and they can customize a plan of whatever works for you. If we're at a point now where We have to do more medical interventions because of the seriousness of this. So, whether that's draining the urine several times a day, there's catheters that can sit inside, or there's different types of surgeries. But relaxing the bladder and draining it has been really helpful. Like, it's one of the few ways that you can slow down this kidney disease, because ultimately you're at a point where you're going to be on dialysis and need transplant. The other benefit of all this, I'll say, is if we started catheterization at night, Alex sleeps way better. So that's another thing to consider. If your kids are waking up in the middle of the night, it could be because they're having these troubles. So just the last part I want to leave you with is, Alex's labs have been stable for many, many years. We had done ultrasounds, there was only mild changes, he didn't really have any UTIs. These issues only arose as he became older and our situation became very dire. And so I would highly recommend to families to be proactive in this testing and get ahead of it so you can slow it down as soon as you know, so that there aren't major issues like what happened to our family. Thank you.
Laura, can I say something real quick?
Yeah, please.
Okay, so I'm
But get a microphone.
Okay.
And Wyatt's mom. Laura and I have visited about this in the past because Wyatt has the same situation in the sense that he's just like every other kid in the beginning, and they test the creatinine test, right, for kidney function, and that's normal in the result. But I went to the doctor and I said, okay, so if my son has abnormal muscles and abnormal muscle use, how can we judge something that's broken down by the muscle? Does that make sense? So that's when our doctor suggested the cystatin C test. It's a blood test. It takes no time at all. And we found out that he has chronic kidney disease also. So he's not allowed NSAIDs or some antibiotics. And he's also had part of each kidney removed. So be proactive in that test. If it's a blood test, just ask your doctor for it, because they're not going to volunteer it because everything looks quote unquote normal on the other testing. Okay.
Can you repeat the name of it again?
Cystatin C. C-Y. She's got it up there. We have cystatin C blood test.
Okay. Go ahead, go for it.
All right. So my name is Sheri Bermejo, from the LA area. My husband is Carlos Bermejo. He's from España. And then Diva is in the wheelchair sitting next to him, and Carmen is my older daughter. She's 15. Eva has Bohring-Opitz. She was born in 2012. We diagnosed her in 2013. Not here in the US, but we sent her DNA abroad. But at that time, our life was upside down. Eva has always had a lifelong history of medical issues, specifically around feeding and going potty. Today she's 11. She is non-ambulatory, she's non-verbal, she is in a wheelchair. But she has learned over these years how to go on the potty. And we know when she has to go potty because she just starts laughing uncontrollably. And we put her on the potty. She does number 2 on the potty. She's in diapers the rest of the time, and she'll go number 1 in her diaper during the day. We know she's done because she's very strong and hard-headed, and so she'll lift herself up off the potty, and then we have to carefully place her down and clean her and put a diaper on her. So what I wanted to talk about are 3, I guess these are terms that I've learned over the last 11 years that I think are important to know about. They may apply, they may not apply to you. Eva was born, and all we knew about her is that she vomited all the time. And I was trying really hard without really a diagnosis to break down why is she so sick, why is she throwing up. One of the things we discovered was that Eva needed to feed at night for her motility while she was sleeping. So we tried to get a lot of slow feeds in at night. But then I noticed when she woke up, we had a dry diaper, she was in pain, crying, and she started vomiting. And that's how I discovered that she was retaining urine. So making those observations, we got in touch with the doctor, and so now one of the things we do to keep her just at night is we place an indwelling catheter before she goes to bed, and that just keeps her urine coming out of her, and she doesn't get upset and wake up in the middle of the night and get sick. Now, many doctors do not, this idea is, that I want to bring up, is called dysautonomia, and that's a very hard word to say, and I've practiced it many times. But basically what that is malfunction of the autonomic nervous system. And so in layman's terms, it's like our brain knows to go when we have to go. The nervous system just somehow slows down. So when Eva was a child, she would have an illness, and then everything would just become lethargy, and she wouldn't urine on her own for days. And she'd also stop going number 2, which was problematic. So we would have to leave the catheter in long term. The other thing I wanted to touch about is the urine retention and then the constipation. Very hard. Everyone, you struggle with constipation. We're hearing constipation, but I think what we were experiencing, and we just learned to experience, was after going in and our daughter would cry for days on end, was this other term called visceral hyperaglesia. I don't know if I said that right, but the term's up there. And what that is that there are moments when their intestines or bladder fills up. It could be with air from the intestines, and it causes uncontrollable pain, but they still can't release the message to get it out. So Eva is very active, and she doesn't have a lot of dysautonomia or slowdown during the day. But in the evening, that's when we see her body slow down. So because of that, every night we do place the catheter, but we also now have to rectally irrigate her with homosaline to get whatever's in her gut, whether it be air or it's liquid stool, really. And that keeping everything decompressed has turned our lives into happier, sleeping is a lot easier. And then the core GI motility gets thrown in with it, and we use Senna, Miralax, and that kind of fun stuff. But literally every child, I believe, is very different, right? So you need to find out what works and really look at the signs that they're showing. I mean, for Eva, I was looking for distension in her belly. And then once you find what works, write it down and just keep doing it. This whole concept of visceral hyperaglesia is most treated with gabapentin. And what Laura had mentioned is our kids are very sensitive. So the normal dose for gabapentin is you start 2 weeks on a small dose, and then the second week you ramp up to twice a day, and the third week 3 times a day. Well, it also causes constipation. So by the time we got to week 2, we're already falling apart. And what's so beautiful is you can stop at a low dose, and if that's working, then why push the limits?
My son has BRS. Oh, sorry. Kaylee has BRS, and I feel like it's the same thing with medication, especially the neurologic medication and also the GI medication. Hypersensitive, have to go slow.
Yeah.
I completely agree.
Yeah, and you could go 3 weeks and be really well and everything's functioning, and then something will happen that will slow down again. So that's the end of my talk. I just wanted to share.
Hi, my name is Alyssa. My daughter Josie is 5.5 years old. She has Bainbridge-Ropers syndrome, and I'm just here to kind of tell my experience with her. And take it or leave it. I'm not a potty guru or anything of that matter, but we just really casually started introducing potty training, and we started with all like the typical potty charts with stickers and blowing bubbles when she went and trying to just make it a very positive experience. And she was into it like 3 times, and then she was over the sticker chart, or she was over the bubbles, and so it wasn't, those catches were kind of hit or miss. But we switched daycares, and her daycare provider was very supportive about helping us on our pottying journey. And so collaboratively, she started taking her to the potty regularly and giving her like a small reward, like an M&M or a preferred toy, something like that. And that started to catch with Josie. And she's also in preschool, and she adores her peers and wants to do what everybody else is doing. So following that role model, that peer role model, going to the bathroom really motivated her. So I think the combination of taking her regularly, getting her into the routine, and having peer models, that was like the biggest game changer for us to really get her to use the potty more regularly. And then another thing is just putting her in underwear. If she has a diaper on, she knows it and she uses it, because why would she want to take a play break if she can just go in her diaper? And so it's kind of taking that leap of faith and being ready with a lot of Lysol to just clean up the messes, because we have a ton of them. And yeah, I mean, we had her in underwear today. That underwear is now in the trash. So you just have to be ready for some ups and downs, and moving forward and moving backwards, and just not being discouraged, because I do believe, the kids are capable of it. It just takes persistence and willingness to clean up a lot of really ugly messes. So that's just a little nice story to share with y'all.
So, my son is Sammy, and he has Shashi-Pena syndrome. I'm the lone family here from ASXL too. Take this off so I can breathe. Sammy was diagnosed in 2016. He was actually a part of the research paper for naming Shashi-Pena syndrome. So when you look up the original kids who are in that paper, you can see his little baby face in there. So it's really special. Sammy is verbal, and he walks. He does not have great balance. He's not able to run. Has difficult navigating through a room if there's a lot of things on the floor. He's been diagnosed with sensory processing disorder, so he's very much a sensory seeker. So he loves to crash into people, and he loves really big hugs. He's very drooly and does not know a stranger. He also has ADHD. And when he got diagnosed with that, his developmental pediatrician told us that he had one of the worst cases he'd ever seen. So, all that to say, at 6 years old, when his special education teacher called me and was like, well, I'd like to talk to you about potty training Sammy, I was just like, what? I couldn't even wrap my head around it. And at the time, I was potty training my son, who was 4 years old and still being potty trained. I was just like, girl, you are on your own. I couldn't, yeah. So my background, I was a preschool teacher in the 2-year-old room. So I have actually potty trained hundreds of children. I was like, I couldn't even think how to do it, because Sammy didn't care if he had a wet diaper, and he doesn't even tell us when he's hungry, let alone tell us when he had to use the bathroom. Like, I couldn't wrap my head around it. And she's like, well, we're going to take a different approach. We're write down a journal of when he is going to the bathroom, because she noticed that his diaper would be dry for long periods of time, and then he would just soak his pants and there'd be a puddle under the floor. And she's like, I think that he's holding it, and if we could figure out the timing of it, set him on the potty at those times, we might have success. And even then I was just like, you go ahead with that. I'll be honest, I was super skeptical. Probably about a month later, I picked him up from school, and she's like, Sammy went poop and pee on the potty today. I was like, what? So it really was, I just feel like it was up to Sammy. He decided when he was ready to do it, and it was like the grown-ups around him paying attention to the cues that he was ready to do it. And so I very timidly took him into the bathroom. I was like, oh Lord, how is this gonna go? Because he loves to switch the lights, flush the toilet 100 times. And, you know, he at one point he took his glasses off and threw them in between his legs, right? Like, oh my gosh. So with time, it was a learning process, just like with anything else, figuring out what are the things that are going to dysregulate him, finding the times of day that when he is the calmest, to take him in there and try. So, those were certainly some of our hurdles, and still continue to be hurdles, just like with anything else. It's not black and white, it's not, it's day to day of how successful we are, but it's such a relief to not have giant blowout diapers multiple times a day. Like I feel like I've gotten hours back in my day to go from just sit him and he goes, and before it was cleaning up whatever mess in whatever room he was in. So that's our journey. He's still in diapers. I have not been brave enough to put him in underwear yet. He still does not tell us when he needs to go. It's more like a timing during the day, 30 minutes to an hour after he's eaten the meal. I'll take him in there, and we have success. That's our story.
Yeah, so I just, in the same lines, if my daughter, she doesn't know when she's hungry or she goes pee or potty, her diaper will be all wet and overflowing when she's asleep, but she won't be bothered, she would be just laying there. So how can we recognize what is the right time even to encourage them to start doing the potty training? Like any experiences?
Yeah, well, I feel like, so it was, like with Sammy, it was, with Sammy, it was keeping a journal of those times. So it's a pain, but figuring out what the rhythm is of her day, like how much the timing of after a meal, when is she having those
Yeah,
blowout diapers?
that's very happens. There's still, because she's different, so there is like continuous meal throughout the day, so it's hard to know.
It's hard to know. There's not a rhythm to it.
Yeah.
Yeah, and sometimes it's just trial and error, like just sitting her there and seeing what happens and going with that. Like, just like with anything else with our kids, nothing is by the book. Nothing. You can't pick up a book and read how to potty train kids like ours. They're just one of a kind. So I feel like trial and error, and if you can find a rhythm in the day, to try it those times.
When Josie was initially starting out, someone had suggested that we try taking her like every half hour. And that's what we started to do, but that's when she would really be annoyed that like every half hour I'm being interrupted and being taken to the potty. So I think it's like finding that balance of going frequently enough that you're not having accidents, but not going so frequently that they're bothered by it. So you might start off with, every half hour and seeing that maybe she doesn't have to go every half hour, we can extend it out from there. And again, putting them in regular underwear, it just makes you aware when they go. If you can tolerate seeing nipples on that, you'll know, and you can start kind of seeing if there are any patterns. But Josie also sort of goes like frequently. She'll go in like spurts where it seems like maybe it's kind of on the spectrum of not fully emptying a bladder. Where if she has a bowel movement that she needs to make, sometimes she'll get some of it out, and then 20 minutes later she's got to go again. 20 minutes later it's again, and it just takes her, some days she'll go 5 times a day, and it just takes her a while to fully empty her bowel. So again, I think that's like a complication with our kiddos, where it's not just like, oh yeah, every morning at 9 she goes and she gets it out and it's done. Some days it's like 9 to 10, she's going every 20 minutes, and I think what really clicked for Josie is when she realized she had control of it, she could just go on the potty on her own and do it and not interrupt her play schedule as much. That's when it really was more successful for her.
How long did it take for that to click? Because I just potty trained my son, it's been about a month. And like you did straight underwear, and I think he has it, he knows all the steps, like go potty, wipe, flush, wash your hands. If he does that, use just one word instead of like bowel movement, or just use potty, he's nonverbal. And sometimes he'll tell us, or sometimes he'll just walk in the bathroom, but I don't feel like all of that connected, like he actually remembers. So like, how long? It's only been a month for us. And so like, before you know this, we're set kind of big clip.
Yeah, that's a good question, because we were like, oh, sorry. The question was, how long does it take to click, and from when you start potty training until they've got it on their own? And I think obviously it's going to be different for every kid, but we started early, like 4 years old, and she's 5 and a half, and she's still having accidents. But I feel like if there was like maybe a 3-month period where it was starting to be more consistent, that she understood it better.
Okay.
But I think there's also going to be interruptions where like they might have it for 4 months, and then something happens, you go on a trip like this.
Well, yeah.
And they don't want to go in the public bathroom and hear all the loud flushing.
Yeah.
Sensory is just too loud. So I think you have to be forgiving that there are any setbacks that when you get home, get back on track.
Yeah.
Yeah.
Any other questions?
Just a comment, about when you know it's time to start. Wyatt, he started straightening his legs and keeping them very firm when he has to go number 2. Like, we know it's time to go to the potty now, because he's like locked in like that. I'm not going, I'm holding it. So we get in there and he goes through. But with him, his urinary, he'll always be urinary incontinent because of the bladder surgery and such that he's had. Because you have ureter seals that stop it from coming down to the urethra, and that does puncture. Because he was refluxing up into the kidneys and getting infected. So with him, it's like constantly dribbling out. It always looks wet. So that's our issue. He won't be able to do it.
For my for my sister, kind of piggybacking off of you, and I think for actually a lot of our kiddos, especially if there's sensory happening, they lack interoception, right? They lack that like feeling that I need to go to the bathroom, and that might be something that they might not gain. I know my own sister doesn't really have interoception with eating or going to the bathroom, so she will just eat until we stop her if she doesn't feel full or really necessarily hungry. And then same with going to the bathroom. When she was potty trained for a bit of time, it was strictly from routine, and we're all talking about different frequencies to start with. I don't know what the answer is, but we picked 4 times a day, and the most successful was right when she woke up. It wasn't necessarily the time, it was just as soon as she woke up, within about 5 or so minutes,
she was on the toilet, and it was just learning that when she's on the toilet, she's gonna go to the bathroom, became like a routine when she had to go. Because I think most when you wake up, you can go a little bit, you know. So that was just her experience, but I would share it.
Sure. Anybody else?
So, you know, I think the urology office told us that your body's always producing urine, right? And so, generally speaking, I would say do it maybe like an hour or so after meals. I think the thing that you do have to be careful for, I mean, even as an adult, right, if you see a pelvic PT, you want to also try to develop some control. And I think if you're doing it all the time, it's not necessarily as good for your body. So generally, like what I've been told is every 2 hours. Like as a general guideline.
One other thing, in case you're a kiddo with a lot of tummy issues, Eva was very complex and we were always doing a lot of medical stuff, so I was one of those parents too. I was like, yeah, I never really learned how to go on a potty. But she surprised me, and it was a nurse who stepped in to take over for another nurse, and they just started putting her on the potty every hour, and then Eva's on so many laxatives and stuff that she does go a lot all day long too. And I found that she was so proud of herself after going. I also learned that she emptied her bowels a lot more on the toilet than in a diaper. So we always try to get her to the potty, and that's her happy face. That means she has to go potty. The other thing with Eva is if you don't keep this up, her whole gut will stop. So that's how important it is to go potty.
There are things, I mean, part of the challenge too is our kids sometimes get tense. So there are things that you can do to try to relax them, like we bought this vibrating thing on Amazon you put on the belly just to kind of massage and calm, or like these TheraBrushes, which I mean you can use for all different things to just kind of calm the kids. Some people find like the peppermint essential oils can help sometimes with pee. So I think just creating an environment, maybe putting on some classical music and dimming the lights and making an environment too that's comfortable for them to want to be able to relax and go.
One of the things that struck me is that Sheri was saying, and we just saw with Eva, is that Asher's got a towel also, and it's almost identical towel, right? So those commonalities and those towels, I think they're much more common among our kids than we think, and that's something to keep an eye on, because I think although sometimes they'll sneak up on us and go without any warning, without telling us anything, and that's much more frustrating than when we see him laughing hysterically. Yeah, exactly.
And you think they're laughing?
Kelly does that too. My son does that too. He'll
He does
start
too.
laughing hysterically,
Yeah,
straightening his legs, and then lots of toots.
yeah.
And he thinks his toots are
Hilarious, right? It all builds and adds to it. I will, just to give a quick example, I know I said it earlier about the importance of engaging in these studies and the surveys that we send out. And I think one of the things here's a real world reason for our engagement in this. It's what Laura and Paula and Sheri were talking about. These tests that they had to do, right? And Alex is now beyond where it could have been caught early, right? That participating in these studies, and as we do the registry and more natural history studies, filling those out so we understand how these disorders are presenting will help the researchers write papers, and once the papers get published, then insurance companies will start paying for this, right? This is how we develop standards of care so that the doctors who are caring for our kids know what the tests are that they should do early. And when those standards of care are published, it's much easier for us to get insurance companies to pay for it.
Can I give an example of that? So when Alex, we were one of the first cases diagnosed with Boston Children's, and at the time I think we were like one of the only people in New England, And I went on Facebook and I found another family and their daughter was undergoing chemosurgery and 75% of the tumors had spread all over her kidney and they had to have a transplant, right? And I went to Wen Hot, I was like, what do we do? You know, and at that time no one knew anything. And I connected him with her geneticist and they eventually published a paper about the correlation between Wilms tumor and Bohring-Opitz. And then it was a lot easier to go for abdominal screenings every few months, of which another family years later found out they had liver cancer. So that's why these things are so important, because we need to put it out there. People need to know. It helps us in getting services, to know what to expect, to do testing, etc. Like we can't just rely on a stream of Facebook feeds, right? Like we need established evidence-based research for this, as well as, you know, having a baseline. So for example, like the EEG study that Bianca will be talking about, you know, under like that setting a baseline so that when we want to go to clinical trials with a drug, we need to be able to show that there's a change in that baseline, right? Their, you know, their brains, their development, everything is improving when we're introducing this drug. But if we don't have a baseline, we can't prove anything, and the trials will fail. So that's just an example of why all this is so important.
And why the foundation is, why that's really the focus of our foundation, is really getting these researchers involved in what we know about our kids, right? Sorry. Any other questions? Comments? Yeah. So I think the next session is the closing plenary. Bianca's going to be speaking about staying involved in research, probably about her upcoming studies, and then we're having a really interesting speaker who is Audrey Davidow, is the president of the Pitt Hopkins Research Foundation and a parent of a child with Pitt Hopkins, talking about how families can make a difference in the research climate, in the research into the disorder. How if we lead, they, you know, and using an example from what she has done and that foundation of how they've really changed the landscape, and hopefully she'll be a really inspiring talk about what we can do as parents and patients to drive research forward on our own terms. So thank you for the panel.